Hi, good evening. My name is Dr. Peter Morrison, and I'm a movement disorder neurologist at the University of Rochester Medical Center in Rochester, New York. I am also the co-director of the Tourette Association of America's Center of Excellence at the University of Rochester Medical Center. And tonight I have the distinct privilege of presenting to you the diagnosis and treatment of Tourette syndrome and other chronic tic disorders. And this topic is near and dear to my heart because I was actually diagnosed with Tourette when I was younger at the age of 10. And so I've had a chance both from the patient side and now from the physician aspect. So I hope you enjoyed tonight's lecture. With regards to this specific lecture, I do not have any disclosures. So overall, what we're going to be looking at tonight in terms of objectives are identify the criteria used to diagnose Tourette syndrome and other tic disorders. We're going to understand the potential health disparities in individuals with Tourette syndrome and other chronic tic disorders, as well as ways to optimize the educator-provider relationship, which is very important in terms of supporting our patients as best as we can. We're going to outline the range of effective management and treatment strategies for patients with tics, including both medication and non-medication approaches, as well as determine the common co-occurring conditions seen in patients with Tourette syndrome and other tic disorders. So first, before we get into the nitty-gritty details of Tourette syndrome, it's important to understand what the phenomenology of tics are. Tics are not insects, they're not tic-tacs, they're not contagious, and they're not signs of mental instability. But rather, from a phenomenologic standpoint, they are repetitive, stereotyped, non-rhythmic movements or sounds or utterances. A lot of times, tics will be associated with what's called a premonitory urge, this buildup or sensation that they're going to occur. They can have a temporary suppressibility component to it, but eventually the movements or sounds will happen. And a lot of times patients will endorse this kind of release or relief phenomenon after completing the movement or sound. And at times they have to do it until it feels just right. And it's important to understand the phenomenology of tics because they are different than other repetitive stereotyped, more rhythmic movements such as stereotypies. So again, understanding what the definition and terminology related to tics is important. So different kind of tics. There's motor tics, which are involuntary contraction of muscles. A lot of times they're in the craniofacial distribution. You can have vocal tics where there's production of a sound. There can be simple tics, which involves just simple contraction of usually one muscle, such as eye blinking, eye rolling, facial grimacing, nose flaring, neck rotation, as well as simple vocal tics, throat clearing, sniffing, grunting, squeaking. But then there can be complex motor and vocal tics, which are sequences of more coordinated movements or sounds, including bizarre gait, kicking, jumping, echopraxia, echolalia, coprolalia. But again, complex motor tics tend to be a little bit less common, and more specifically, coprolalia is actually very uncommon. Most studies look at around less than 10%, but most of the time you'll be seeing simple tics, but of course they can have complex motor and vocal tics. So now we've defined what tics are, so it's important to understand what different type of tic disorders that we have. First is a provisional tic disorder, also known as formally a transient tic disorder. And these are the presence of either motor and vocal tics for less than a year. Overall, it is very common in children to have tics, at least 10 to 20%, depending upon what source you read, but they last for less than a year and they resolve. 1% to 3%. At times, tics can persist for greater than a year, and that's when we transition into what's termed a chronic tic disorder. And there's 3 different types of chronic tic disorders. First, those individuals who have only motor tics, but no vocal tics for greater than a year. That's a chronic motor tic disorder. Then you have those individuals who have only vocal tics, but no motor tics for greater than a year. That's a chronic vocal tic disorder. Then there's Tourette syndrome, which is the combination of at least 2 or more motor tics and at least 1 vocal tic for greater than a year. Now, in the end, it's the same pathophysiology that's occurring, whether it's chronic motor, chronic vocal, or both in terms of motor and vocal. But Tourette syndrome is the term utilized for 2 or more motor tics and at least 1 vocal tic for greater than a year. So going into Tourette syndrome specifically, looking at the background and epidemiology, this was named after Dr. George de la Tourette in the late 1800s. And unfortunately, it was really regarded as a psychological condition initially, but obviously through extensive research and understanding of the disease, this has changed to understand it's a complex neurodevelopmental disorder with potentially genetic components, though obviously a lot of research regarding the genetic aspect of the disease still needs to occur. With regards to prevalence, again, depending upon what source you read, about 0.5 to 1%, and it is affecting males more than females in a 4-to-1 ratio. But before we get into the other aspects of Tourette syndrome, I think it's important to try to understand, are there health disparities in patients with Tourette syndrome, and what do we know thus far? Well, unfortunately, the data is limited. There isn't a lot of research in looking at the health disparities in patients with Tourette syndrome. But from the limited research in terms of what we do know, it appears that lower socioeconomic status identified as a risk factor for TS or chronic tics. In addition, people publicly insured in terms of TS patients have higher tic severity and higher comorbidity rates than privately insured patients. And diagnosis is more common among white, non-Hispanic children compared to Hispanic or Black non-Hispanic children. And again, I think our information is very limited. And this is an area of research and understanding that we certainly need to advance further in terms of understanding what the real health disparities are in patients with tic disorders. There's also limited data in regards to time of onset of symptoms to diagnosis, as well as the comorbidity rates across different racial, ethnic minorities and socioeconomic background. So the take home is that unfortunately it's limited, but certainly we need more research going forward looking at this. So with regards to Tourette syndrome, again, onset typically is less than 18 years old by definition. The average age of onset, though, is around 5, 6, 7, 8 years old. And what I would say is the onset of tics after the age of 21 in 30s, 40s is very, very unusual. So if you get that individual, you have to take a good history to see if maybe they did have tics as a child, now they're reemerging again as an adult, or truly there is no evidence of tics as a child, and now they're having adult onsets, and that's atypical. Talk about, again, onset 5, 6, 7, 8 years old. They tend to peak 9, 10, 11, 12, 13. And in the majority of individuals, I'd say about 75%, tics do improve in frequency and severity as they get into young adolescence and into adulthood. In addition, tics wax and wane. They come, they go, they ebb, they flow. And that can be hour to hour, day to week, or day to day, or even week to week. And a lot of times, as with most movement disorders, certainly tics are worse with stress, anxiety, heightened emotions, or anticipation. And that could be good or bad emotions, right? So, it is, again, something that we see commonly in almost all movement disorders, whether it's tremor, tics, where symptoms do worsen under stressful situations. And one of the take-home messages from today is that when you see an individual with tics, tends to be a high association with other comorbidities, including ADHD, OCD, anxiety, and depression. And as clinicians, we need to be very cognizant about this in terms of screening individuals who we see have tics for these other comorbidities, because it actually tends to be the comorbidities that persist into adulthood and day-to-day can be more functionally impairing. So this is a great graphic representation back from actually the Journal of Pediatrics in 1998 that basically queried individuals in terms of when they thought their relative tic severity was worse based upon age. And as you can see, onset again 5, 6, 7, 8, tends to peak 9, 10, 11, 12, 13, and the severity improved with age. Now, this is also very subjective, right, in the sense that is worse severity related to the amount of tics you have, the frequency of tics. How about one tic that's very large amplitude that's bothersome? Is that considered more severe? So certainly there's some subjectivity to this, but a lot of times we see worsening of tics 9, 10, 11, 12, 13, but in general tend to improve with age. Another topic that I think is important in terms of moving on to the treatment of tics is understanding and improving upon the educator-provider relationship. Providers, such as myself, can be very helpful with a patient who may be struggling at school. And there's different ways that we can help support our patients. We can recommend and encourage outside therapies, such as physical therapy, speech therapy, occupational therapy. We can write letters to school, at least stating what the diagnoses are, other comorbidities, how the symptoms impact day-to-day, as well as recommending potential accommodations, and if needed, depending upon the severity of symptoms, a full school psychological evaluation, again, to try to get at all of the underlying diagnoses. If it's not entirely clear whether it's just ADHD in addition to tics, is there anxiety and ADHD, OCD and anxiety? Sometimes it can be helpful to have a full psychological evaluation to understand the gamut of symptoms that an individual may have. And again, as you'll hear throughout the lecture, it's not just necessarily the tics that students will struggle with, but the ADHD, OCD, learning disabilities, executive function deficits, and sensory processing. So these are all, again, symptoms that we need to screen for when we see patients with tics. Here's just a list of additional resources for educators, and we would certainly be able to provide this list at the end of the lecture again. So now I'm going to play a video of an individual with Tourette, and I think it's important to kind of listen to his story. This is a younger adult that we have in our clinic in terms of how the tics impacted him as a child, what he's done for the tics, and how it's affected day-to-day activity. So now I'm going to share the video.
All right, so you're how old now?
I'm 23 years old.
Okay. And do you remember how old you were when anyone first pointed out to you that you had some unusual movements?
I was about the age of 6 to 7 years old, and I was in about first grade when I was first told about myself. Also, one time that when I was a little bit younger, I had probably about maybe 4 or 5. I was at my one friend's house, and I was having one of my tics, and I was playing a video game, and my legs were going like all over the place, and I was making facial features.
Mm-hmm.
And my mom's friend called her to let her know about it. She thought there was something wrong with me. She thought I was having a seizure or something.
Yeah.
But my mom was like, "Oh no, he's fine. It's just what he does all the time."
Right.
So.
All right. Have you found that medicine has helped you control these?
The medicines helped me keep them underneath control, but that's the key thing. It's kept them control. It's nothing that's completely helped me get rid of it or anything.
But the only time it bothers you is what? When do they actually bother you? Is it...
A lot of the times when they bother me, it's stress. When I'm kind of zoning out and then daydreaming and things of sorts, or typically I notice they do come out when I'm not taking my medicine and stuff like that.
But how does it bother you? Does it cause pain or?
Not so much pain, maybe more tension.
Mm-hmm. Where is the
top part, around the shoulders and neck?
Mm-hmm.
Is where I notice a lot of it. I get some tension in the insides of my hands from when I do different hand stuff and I strain and stuff with my hands. But as far as any other pain, I don't really feel that much pain. I'll get some neck kinks and stuff and sorts. But
if you could do something tomorrow that would cure this completely, would you do it?
Yeah, I guess. I mean, I wouldn't want to take away what I've learned from it, I guess, because it's helped me learn to try to I guess be more of an individual.
Mm-hmm.
And because it does kind of make it so where I have to learn twice as harder, I guess it makes me more of an independent in terms of trying to be a little bit more stronger in learning aspects. So I don't want to take away from that what I learned from it, but at the same time, to be able to get rid of it, to help me be able to learn better, not having to be a distraction and be able to, be able to do my homework in an hour instead of having to take 2 hours to try to control my tics and sorts.
Right.
I wouldn't mind it at all if there was a way that I could do something to find a cure for it. Yeah.
All right, so that was, a great video to really look at an individual with tics in terms of describing how the tics affected him as an individual, how medications affected him, as well as hearing from the physician's standpoint how they affected him. And that's a really great segue into the next aspect of our talk, which is the considerations and treatment of Tourette syndrome and other tic disorders. And the first line question that you always have to ask yourself as a provider is, do I need to treat? Because in the end, just because someone has tics, or whether that's tremor or chorea, just because they have movements doesn't necessarily mean you need to treat. You only want to treat if they're bothersome or disruptive to the individual and to the patient from a day-to-day standpoint. And so you want to consider impact of tics on activities, school, social interactions, self-esteem, things like that. A lot of times just educating the patient, their family, and other school members can be just as helpful when making the diagnosis and not necessarily needing treatment. If you are going to treat, the goal is tolerable suppression and improvement in frequency and severity of symptoms, but not necessarily elimination of symptoms. Treatment of tics to appease the parents is obviously not recommended. What do I mean by that? So certainly on occasion, I get the patient that comes in and the mother or father is saying, Johnny, I see him on the soccer field and he's ticking 200 times. I feel so bad for Johnny. We need to do something. So I asked Johnny, I say, Johnny, are you bothered by these tics? And he says, no. So obviously in the end, it comes down to the individual and the patient, and ask the patient directly how bothersome the tics are. In addition, you want to treat the most bothersome symptoms first. What do I mean by that? Well, a lot of times it's not just the tics, but there can be comorbidity symptoms of anxiety, depression, OCD. And sometimes it's the anxiety that's really the driving factor, or the OCD. So again, you want to triage what symptoms are most impactful day-to-day to the individual and the patient, start there and see what's left over and reevaluate. Also remember, tics wax and wane, they come, they go. They ebb and flow. So there can be a period where they're worse, but the natural course is that they're going to improve. In addition, anytime a new life event, occurs, whether that's death in the family, starting school, exams, certainly tics will be transiently worse. And again, a lot of times tics improve with age. So it's really important as the individual gets older, if you are treating them, to constantly reassess, does my patient need to be on medications? So when we talk about the treatment approaches for patients with tic disorders, I just want people to be aware that the American Academy of Neurology in 2019 published updated practice guidelines and summaries in regards to patients and treatment of tics, including both medication interventions and non-medication interventions, particularly CBIT. So when we look at first-line treatment of tics, in my opinion, that is going to be comprehensive behavioral intervention for tics, also termed CBIT. I really try to go for CBIT first compared to medications. It is a form of habit reversal therapy. Now, I don't like that term habit because I don't think tics are habits, but basically it utilizes that premonitory urge that patients have with tics to become more aware of them. As a result, they then develop what's called a competing motor response. And again, there's other day-to-day changes that you can make in activities in helping reduce the tics. But here's a basic kind of philosophy is that, let's say my bothersome tic is a neck rotation to the left. When I feel that urge or build up, maybe I'll just tuck my chin to my chest, wait till that urge passes, and then release. So you develop a competing motor response in that you can't do the chin tuck as well as the neck rotation to the left. Now, some individuals will ask me, Dr. Morrison, am I just trading one tic for another? And the answer is no, because the competing motor response does not satisfy the urge of that original tic. In addition, patients will ask me, well, what if I have 20 tics? How am I going to develop a competing motor response for all of those tics? What I say is you focus on the tics that are bothersome. Take the 2 or 3 that are most frequent, most intrusive. You treat those, and a lot of times that can improve quality of life. Overall, CBIT is typically offered by psychologists, neuropsychologists, and occupational therapists. And overall, the Tourette Association of America has been doing a really great job in terms of trying to train up individuals for CBIT, because access to this obviously becomes one of the rate limiting steps. Typically, it's about 1 session a week for about 8 weeks, but obviously that can be modified based on how the patient is doing. But in general, is 8 weeks. So it's good for me to say that CBIT is first line, but where's the medical evidence for that? So we like medical evidence as physicians. Well, the first was a randomized controlled trial of 126 children aged 9 to 17 with TS or chronic tic disorder. They were divided into 2 groups, 8 sessions with CBIT during 10 weeks with behavioral therapy, or a controlled treatment group consisting of just supportive therapy and education alone. And what they found was that the behavioral intervention with CBIT led to significantly greater decrease in the YGTSS, which is the Yale Global Tic Severity Scale. That's the motor outcome that we use, compared to the control group. In addition, significantly more children receiving the behavioral intervention compared with those in the control group were rated as either very much or much improved on the Clinical Global Impressions Improvement Scale. Dropout rate was low at only 9.5%, And in addition, not only was there benefit at the end of the study, but 6 months out, they found that 87% of individuals were continuing to respond to the behavioral intervention. So that's also very important, not only at the end of the study, but 6 months out, there is durability of the treatment. So then they took it a step further. They did a randomized controlled trial of 122 adults aged 16 to 69 with Tourette syndrome or chronic tic disorder. Similar terms of treatment group of 8 sessions CBIT versus the control group of 8 sessions of supportive therapy. And they found that the behavioral intervention with CBIT resulted in significantly greater decrease of the YGTSS compared with 8 sessions of supportive control treatment. In addition, significantly more adults receiving CBIT were rated as being very much improved or much improved on the Clinical Global Impression Improvement Scale compared to the control treatment. Dropout rate was not fairly dissimilar in terms of 13.9%, regardless of which group that they looked at. And again, the treatment gains were durable with continued benefit 6 months post-treatment. And so here's a graphic representation in regards to the Clinical Global Improvement Impression Scale. In the child study, about 52.5% were very much or much improved, and the adult study was 38.1%. So overall, again, CBIT, in my opinion, is the first line for treatment of bothersome tics. But in the end, sometimes access to care to CBIT is limited, or we try CBIT and the tics continue to be there and are bothersome to the individual. At that point is when we have to consider pharmacologic intervention for treatment of bothersome tics. Enlisted here are many in several different categories that we use for treatment of tics. And I will be going through most of them, but it's important to be aware of these different medications. And some of them you may not be prescribing, a subspecialist will, but it's important to understand that they're out there. So there's the alpha-2 agonists, the anti-dopamine blocking agents, Topamax, VMAT2 inhibitors, as well as botulinum toxin. And one of the recurring themes throughout this lecture will be the treatments of comorbid conditions if they're there, including ADHD, OCD, and anxiety. So let's go into the alpha-2 agonists. So if I have to go to a medication, alpha-2 agonists are definitely the first line treatment from a pharmacologic standpoint. The mechanism of action is that they are agonists at the alpha-2 receptors within the central nervous system, which then reduce sympathomimetic outflow. As I mentioned, they're considered first-line pharmacologic intervention for treatment of tics. In addition, they're also effective as a non-stimulant approach for treatment of ADHD symptoms. So at times, if you have a patient with both tics and ADHD symptoms, it can be a potential 2 for 1. But guanfacine or the alpha-2 agonists tend to be a little bit less in terms of efficacy for treatment of ADHD compared to stimulants, which I'll touch on, but certainly it is a reachable option to treat both tics and ADHD. They're potentially less potent regarding benefit compared to the dopamine blockers, but in general, they have a lot less side effects compared to the dopamine blockers, and they still have evidence of mild, moderate improvement in tics. So again, that's typically what I go with. Most of the common side effects are going to be sedation, orthostatic hypotension, bradycardia, again, because their mechanism actually is to lower blood pressure and heart rate, and that's where some of these side effects can occur. So with regards to which 2 alpha-2 agonists we have either clonidine or guanfacine. In my clinical practice, I like to use guanfacine more than clonidine. I feel that it's a little bit less sedating, but obviously both are very reasonable options that I'm going to go through. So if you're going to try clonidine, I usually start 0.05 to 0.1 milligrams at night. You go low and you go slow, adding at the same interval every couple weeks, and it can be divided BID or TID. Maximum dose per day, I say, is about 0.4 to 0.6 milligrams before you get law diminishing returns of increased side effects versus benefit. CAPVA is the extended release formulation, and per the AAN, on their updated treatment guidelines, they said that people receiving clonidine are probably more than likely than those receiving placebo to have reduced tic severity. Again, I'm going to put the official AAN recommendation in quotes based upon their most recent treatment guidelines. Next is guanfacine. So this is the medication that I tend to go to first. I start again 0.5 milligrams to 1 milligram at night, increase slowly by the same interval at every couple of weeks. Most of the time I can get away with it dosed daily because it has a little bit longer half-life than clonidine, but certainly it can be dosed BID if needed. Maximum dose is about 4 milligrams daily. As I mentioned before, in my clinical opinion, it's a little bit less sedating than clonidine, but certainly can happen. And Intuniv is the extended release formulation. For the AAN, people receiving guanfacine are possibly more likely than those receiving placebo to have reduced tic severity. So next are the antidopaminergics, or the dopamine blocking agents. Again, you may not be prescribing these medications. A lot of times they will be prescribed by subspecialists, but it's important to understand the different options that are available because you may be seeing them. There are two groups, the typical antipsychotics and the atypical antipsychotics. With regards to the typical antipsychotics, these are considered most likely the most potent tic medication because they have the most D2 receptor blockade. But given that increased affinity for the D2 receptor blockade comes the risk of side effects, not only sedation, weight gain, akathisia, but extrapyramidal side effects of tremor, Parkinsonism, in different tardive syndromes, including tardive dyskinesia. Whereas the atypical antipsychotics bind to the D2 receptor a little bit less compared to the serotonergic receptors. Therefore, their probably efficacy when treating tics is a little bit less compared to the typical antipsychotics, but the risk of extrapyramidal side effects, tardive syndromes, are a little bit lower, though obviously are still there. The typical antipsychotics that we use, if possible, are going to be haloperidol or pimozide. With regards to the atypical antipsychotics, the ones that I use on occasion are either risperidone or Abilify. What I would say is with the atypical antipsychotics, weight gain is the most common and bothersome side effect. In addition, it's important to work with pediatricians monitoring glucose, elevated serum lipids, because it certainly can contribute to the development of metabolic syndrome. And again, you have to monitor for extrapyramidal side effects, different tardive syndromes, tardive dystonia, dyskinesia, but they're a little bit less likely. And what I would say is the risk of tardive syndromes increases with the dose, duration, and age. So again, you want to use the lowest effective dose for the shortest period of time if needed. So let's say you've tried CBIT, you've tried an alpha-2 agonist. The tics are still there, they're still bothersome, but you're not quite sure whether you really want to escalate to a dopamine blocking agent. Well, that's where Topamax can potentially be effective. It has multiple mechanisms, including carbonic anhydrase inhibition, as well as potentially potentiating GABA-A inhibition. And there was one phase 3 study in 29 children and adults with TS. And the mean dose that was used throughout the study was around 118 milligrams. And it did show on their endpoints that there was improvement in the outcome scores for tics. With regards to side effects, there was a high dropout rate in that clinical study related to cognitive dulling, reduced appetite, weight loss, paresthesias, and or kidney stones. So that's clinically one of the drawbacks when using Topamax, or the potential side effects. But again, you can consider whether patients have co-occurring headaches and tics. Would that be a combination to potentially treat both? In terms of how I dose it, I start anywhere between 12.5 milligrams to 25 milligrams daily, and I increase by similar intervals every 2 to 4 weeks. With regards to the AAN, topiramate is possibly more than likely than placebo to reduce tic severity. So whenever I give a lecture, medical marijuana always comes up. And so I thought I would kind of get ahead and discuss it here in this lecture. And overall, I would say medical marijuana, whether it's also talking about THC, CBD, is a very hot topic in neurology, not only with treatment of tic disorders, but in treatment of Parkinson's and tremor and chorea and seizures. So it's important to understand what the data is when we talk about medical marijuana in treatment of tics. And unfortunately, it's very limited and it's not there. And I'll go through the 2 studies that we have. The first was in 2002, which was a randomized double-blinded crossover study of 12 adults with TS. And what they did was that they gave a single dose of THC, and they did it for 1 dose, and they basically rated their score in terms of the tics. And then they had a 4-week washout period, and then they were either given the placebo or, again, 1 dose within the tic severity scales rated. And what they found was that there was no significant differences between the treatment groups and clinician-rated measure on the YGTSS. The following year, there was another randomized, double-blinded, placebo-controlled study of 24 adults with TS. So the amount of patients enrolled was a little bit more in 24. They had a THC group with 10 milligrams daily, so there weren't varying doses. And this time, they did the treatment period for 6 weeks rather than just 1 treatment, washout, treatment 4 weeks later. They did it for a full 6 weeks. 7 patients out of the 24 dropped out or had to be excluded. And again, what they found was that there's no significant difference between THC and placebo group when looking at the YGTSS. So overall, when we look at medical marijuana and the AAN summary and recommendations, here they are. Cannabis-based medications should be avoided in children and adolescents, not only due to the paucity of evidence, but due to the association between cannabis exposure in adolescence and potentially harmful cognitive and affective outcomes in adulthood. Compared to placebo, cannabis-based medications are associated with increased risk of short-term adverse events, including dizziness, dry mouth, fatigue, and there's limited evidence that THC dronabinol is possibly more than likely than placebo to reduce tic severity in adults with TS. So in regards to summary, when we talk about treatment recommendations for the primary care provider, the first and most important question is, do you treat or not? If the tics are not impairing the individual patient day to day, then I would monitor symptoms. If the tics are bothersome to the individual, then I would consider treatment. And in my opinion, CBIT is first line prior to starting pharmacologic therapy. But if you have to start pharmacologic therapy, alpha-2 agonists are the first line treatment, especially in those individuals who may have ADHD. If you have to potentially go past alpha-2 agonists, it wouldn't be unreasonable to get a consultation with a subspecialist, whether that's a pediatric neurologist, child psychiatrist, before initiating antipsychotic medications. And as we're going to go into the next section of the lecture, it's important to screen for the common comorbid conditions in patients with chronic tic disorders, because those symptoms can also be impairing from a day-to-day standpoint. So let's get into it then. This is a great graphic representation, and I love utilizing this that the Tourette Association of America made. And basically here, a lot of times they show that the vocal and motor tics are at the surface. That's what we tend to focus on. But underneath the surface, there can be a lot of other co-occurring conditions and symptoms, including and not limited to ADHD, anxiety, depression, OCD, behavioral issues, learning disabilities, rage episodes. So it's incredibly important for especially primary care providers that if you see an individual with tics, please begin to screen for these common comorbidities, because often you will see them in conjunction. So the first one that I would say, at least in my opinion, is the most commonly seen would be ADD or ADHD. Again, depending upon what resource you read, I would say about 60% of patients with TS or chronic tic disorder also has ADHD. Over the years, there's been a little bit of a misnomer and concern whether stimulants worsen tics. And I just want to make everyone aware that there's a recent meta-analysis in 2015 of controlled trials that did not support an association between new onset or worsening of tics and psychostimulant use. So the bottom line for me is that if you have tics and ADHD, and the ADHD is a very impairing symptom, I would not hesitate to treat with stimulants if needed. Now, is it to say that certainly there are individuals that report back to me that their tics worsen on stimulants? Sure. But the bottom line is that if the ADHD is there and it's the most impairing symptom, definitely try to treat it with a stimulant if possible. With regards to the different treatment approaches, again, you have methylphenidate, Ritalin, Concerta, and then you have the amphetamines such as Adderall. You can also use non-stimulant approach, such as the alpha-2 agonists, which we've already covered, in guanfacine and clonidine. And then there's also non-stimulant approach, including atomoxetine. So overall, ADHD is very common. And if it's there, you should treat it and don't necessarily be concerned about worsening of tics or onset of tics in patients with ADHD, as our studies have shown that is not necessarily the case. Next are mood disorders. So anxiety and depression are also very common in individuals with TS or other chronic tic disorders. And what I would say is the onset of symptoms can be a little bit later compared to tics and ADHD, kind of in early teen years. But what I would also say is that I see patients across the spectrum of both children, adolescence, and adulthood. And it really tends to be the mood disorders and the co-occurring conditions that tend to persist into adulthood and are most impactful from a quality of life standpoint. So most of the time in adult patients, I will be treating and addressing their anxiety, depression, OCD in about 75% of the case compared to about 25% of adult individuals for their tics. When we talk about treatment approaches, certainly doing cognitive behavioral therapy can be helpful, but obviously there are very effective medications to help with anxiety, depression, including the SSRIs, SNRIs, and other mechanisms of action, including Wellbutrin. OCD is another very common comorbidity that we see in patients with Tourette syndrome. And sometimes it can be very difficult to differentiate what a complex motor tic is compared to a compulsion. What do I mean? So let's say someone comes into my office and knocks on my chair and goes 3 times. I say, "Why'd you do that?" And I say, "Well, I kind of had this urge, this buildup, kind of felt better after I did it." Maybe that's going to be a complex motor tic. Whereas the next patient comes in and goes, same thing, they knock 3 times. I say, "Well, why'd you do that?" They said, "Well, I needed to do that in order to prevent my dog Sticky from dying." So that is more of a compulsion where you have this intrusive thought for which then the compulsion occurs to try to reduce that anxiety related to the compulsive thought. But at times it can be very difficult to differentiate what a complex motor tic is compared to a compulsion. And then I jokingly use the term compulsive, but obviously it's important to try to differentiate because the treatment approaches can be different. CBT can be very, very effective as a behavioral intervention for individuals with OCD, but also there are medication options. Typically, I like to use fluoxetine, paroxetine, sertraline. At times, treating OCD can take a little bit higher dose compared to that of anxiety and depression. Then, of course, there's other medications like clomipramine, but I typically go with the SSRIs if needed. Other comorbidities that we can see: behavioral disturbances, conduct disorder, rage episodes. Again, treatment is going to definitely be with behavioral intervention, developing strategies for when these symptoms occur. I did list some medications, but it's a little bit outside of my realm of comfort when we talk about treating kind of behavioral disturbances. And that's where sometimes having a child psychiatrist may be helpful if there's ongoing and difficult to treat behavioral disturbances. In addition, there can be individuals with learning disability, and it's important, again, to support our patients as much as possible in terms of advocating for IEP, additional resources, psychological testing, because certainly that can make the difference for an individual in school. This is a great graphic representation, kind of just showing overall what I've talked about with onset of symptoms and what tends to linger on. And you can see that tics and ADHD tend to have a similar kind of onset, 5, 6, 7 years old. The mood disorders tend to have a little bit later on in terms of onset. But what you see is that the comorbidities tend to persist into adulthood, where a lot of times tics improve in frequency and severity into late teenage and early adolescence and adulthood. So overall, when we talk about the summary regarding this lecture, Tourette syndrome is absolutely a complex neuropsychiatric condition involving tics as well as potential comorbidities of anxiety, depression, OCD. In general, tics improve with age, but it's the psychiatric comorbidities that tend to persist with age and at times can be most functionally impairing. Not always, but that's the general trend. Overall, you want to treat the most bothersome symptom first. If it's the anxiety, you treat that first. If it's OCD, treat that first. If it's the tics, treat that. A lot of times patients will have bothersome symptoms across all those boards, but you really want to try to triage what is most functionally impairing, start there, and go from there. In addition, you want to consider both non-pharmacologic, CBT, and pharmacologic interventions for tics in the comorbid conditions. And that is it for today's lecture. Here's a reference in terms of all the sources that I use. And I always, at the end of my lecture, like to thank my family as they've been incredibly supportive. They give me the opportunity to do this. And here's my wife, Jessica, as well as our 2 children, Ryan and Emma. And that concludes today's lecture. And I'll be looking forward to answering questions.
Thank you so much. I was going to do the square, but I guess I'll wait since I'm supposed to be in charge here. So Angela, do you want to unshare your screen?
Yeah, sure. I hope everyone could see that and it worked out well.
Oh, right. Sorry.
No, it's fine. That works for me. I see Dr. Morrison here. Hi.
Hey, Dr. Morrison. I'm Jennifer Jewell. I'm the chair of the Maine AAP Education Committee. So that's my role here. By day, I'm a pediatric hospital-based pediatrician, pediatric hospitalist. And in full disclosure, we have a Peter Morrison, who's a pediatric neurologist here in Portland, Maine. So I don't know, maybe it's a thing that that's a popular neurology name. So Let me just see. I'm going to check the chat, but while I'm doing that, I had a question about for CBIT. Is it important that the patients are suppressing their tics with the tools that are given during that, even when they're like alone or in non-bothersome situations? So I guess what I'm asking is it okay? Does the toolkit allow you to tick in some situations, but not all? Or is the idea to try to suppress the tics all the time?
So it wouldn't necessarily be, I think, to suppress the tics all the time. I mean, certainly individuals outside of CBIT find their own ways inherently, right, to kind of try to reduce the tics when they're in public or in school, and then they come home and then there's just this escalation, right, of tics. But really what it tries to do is develop a competing motor response that is, you know, a little bit easier for the patient to do or not necessarily as noticeable. Again, it's simplistic terms, you know, way to describe it. It's a little bit more complicated than that. But the one that I use, you know, with kind of the chin tuck real quick is definitely not as noticeable as more of a kind of head rotation tic. And so, you know, obviously the goal is not to try to have patients suppress tics, you know, because they're involuntary and they happen, but it's to potentially have even more control over them, understanding that premonitory urge and how they potentially adjust it and, you know, do a different type of movement that may be more subtle.
Oh, that's perfect. Thank you. All right, so we've got a bunch of questions here. So there's a question about in new onset tics what do you think about testing for pandas?
Yeah, so what I would say is upfront, obviously pandas is a very emotional topic, okay? It's a controversial topic. And, you know, we could spend an entire lecture, you know, talking about pandas and going through that. You know, so what I would say overall is that in my medical opinion, based upon the available evidence, there is no support in terms of the association of strep and the development of tics or tic disorders. What I, you know, am happy to do, and I can share my screen if you'd like, is actually there's a great review in the Journal of Pediatrics published in 2018 addressing this topic in terms of looking at all the evidence over the years to try to look at that potential association. And what they found was that there was no definitive link based upon that. So I'm happy to share my screen just to show that article, because this is a topic I get every, you know, this and medical marijuana are the two main ones that will not escape a lecture of tics. So I understand it's an emotional topic, you know, and so let me just share my screen.
Sure.
Oh, sorry, unable to do it, but it's basically, I'll just read it, the title. It's a pediatric neurology perspective on pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection and pediatric acute onset neuropsychiatric syndrome. It's, you know, authored by Don Gilbert, John Mink, one of my mentors, and Harvey Singer. So I'm happy to share, you know, I can give this article to Angela and then she can disseminate it to everyone because I think it's the best review regarding that.
I changed the settings. If you want to go ahead and share, I think you should be able to now. Sorry about that.
No problem. So I'll just highlight the screen here. So this is it here. So I'm happy to forward this article, but I think it's the best resource that we have that goes through systematically all the different, you know, trials or, you know, cases looking at it objectively in terms of the relationship of strep and, you know, pandas. So in my clinical practice, obviously I do not. If strep is there and it's causing keratitis, sure, obviously, you know, you should treat. But if there's strep infection and then ticks, let's say, or ticks, and then you test and there's strep, I do not recommend treatment of the strep infection just because of the presence of ticks. Again, my opinion, very emotional topic.
That's okay. We're emotional people.
There you go.
So Sid, you ask male versus female. Are you asking about the incidence of Tourette syndrome? Because I think it was 4 to 1. Or was there something else?
How it presents.
Oh, you're asking about, is there a difference in the symptomatology?
Yeah, it seems like the girls, it's more kind of OCD and the tics aren't that big of a deal. And with the boys, the tics and ADHD are the big deal. I guess the correlative question is, when does tics with ADHD become Tourette's, and does that matter?
Yeah, I guess I'll take a step back on that. So in terms of typical onset of what I see, you know, the ADHD tics are similar in terms of time frame. most of the time, the OCD, anxiety, depression seems to be a little bit later on. I don't necessarily, at least in my clinical experience, tend to see a lot of necessarily difference of the males having more tics and ADHD versus the females having, anxiety, OCD. What I would say, and again, this is opening a little bit of a can of worms in that sense, is that we have seen, and I'm not sure if you all have seen it too, kind of the increase in acute onsets of tic disorders in individuals age range from 14 to 17 that are really these explosive acute onset of complex motor and vocal tics. And it tends to be in what we're seeing females 14 to 17, right? And that goes against the natural history of tic disorders and Tourette being 4-to-1 male to female. So again, that's a phenomenon that we're seeing in the pandemic, unfortunately, over the last year. But in terms of, going back to your original question, I don't tend to see too much of a difference. I definitely have the majority of my patients that have, males that have tics and significant OCD, anxiety, depression, than those females with just tics and maybe ADHD or nothing else. So at least in my experience, I don't tend to see too much difference in that regard.
So there's a question about the pathogenesis or physiology of tic disorders. So do we really know, or are you just going to say something like brain chemistry?
No, so I mean, I can go a little bit more with that. Obviously, there is some thought regarding dopamine, right? In that, antipsychotics, the dopamine blockers help to reduce tics, but it's all not necessarily related to upregulation of dopamine or things like that. There are some studies looking at paralbumin in terms of whether there's reduced levels of paralbumin in the striatum of patients with tic disorders versus not. And so it gets a little bit complex in that regard. But yes, in general, it's not well known. But those are kind of the main theories that people are thinking. Also, there's some potential evidence in animal models, whether the GABAergic system is involved. And so that's why people think, oh, benzos, but obviously benzos aren't really, as effective, and they have all the side effects. So, in terms of looking at dopamine, paralbumin, parvalbumin, or, the GABAergic system, it's some sort of probably complex circuitry within that. But I don't think we're 100% definitive yet.
So there are a couple questions from the same person named Karen about can neurofeedback help? And also, this is somebody who's like way smarter than me. In adults, would TMS be helpful for tics?
In terms of transmagnetic stimulation, I presume. So we don't have any, I presume that's what they mean by the abbreviation.
I think so.
Okay. Yeah, so we don't have any evidence at this point regarding TMS in terms of, especially in adults with tics. So it's something that I, obviously wouldn't recommend, though certainly, I think we need a lot more research. That actually is something that comes up in my Parkinson's patients. One of my patients actually is doing it himself, and I'm like, oh my God, and he swears that it works. Again, right now we just don't have the evidence for that. So that would be for TMS, and the other one was neurobiofeedback. Yeah, so I think it's certainly something to consider. What it really comes down to is access for a lot of these treatments, right? Whether it's CIBT, neurofeedback, things like that. And that's one of the shortcomings, unfortunately, that I think we have. And I don't know if that's necessarily the case in Maine, but it's certainly something that we're seeing in New York State. Is really access to these different providers, not only clinicians in a sense of getting the diagnosis, but the treatment with CBIT and having trained personnel to do it. Mm-hmm. I mean, interestingly, with the pandemic, given the development of telemedicine, it's actually become a little bit more accessible. And so we're finding ways to reach those communities that wouldn't necessarily have access to them. So, I think it's certainly definitely to think about, but I think it, comes back to access, really.
Well, thank you so much. Let me just make sure nobody else, I either missed a question or anybody else wanted to ask something differently. And then, so also in the chat, Angela put in a SurveyMonkey link. And so I'm wondering if we can keep the Zoom going a little bit longer. Anybody can like drop off at this point. But Angela, would you mind putting up the last slide as well? So just so we have the SurveyMonkey and the QRS code thingy.
And I can share my screen real quick about the stimulants in ADHD.
Yeah, please.
Yeah, just so this is from the Orange Journal. Let me just show. I always have these up. So this is the meta-analysis in 2015. that was looking at ticks, and the use of stimulants. And so it's a really good review article. And again, it's not to say that I don't have those individuals that report back to me that their ticks get worse, right? So, but this is at least the evidence nowadays sort of suggesting that it isn't the case, and that, certainly if the ADHD is there and it's the driving force that's impairing quality of life, then I say try to treat it with a stimulant and see what happens.
Yeah. Angela, did she make it so you could share your screen again? Okay, cool. Well, thank you, Dr. Morrison. I don't see anything except comments about how wonderful this was and practical. Did anybody else have anything they wanted to say?
Dr. Morrison, I'm Annie Coates. I'm one of the pediatric pulmonologists, and I have seen children with Tourette's and more in the setting of quote unquote like habit cough or psychogenic cough, both terms that I don't care for. But we've had some good success with medical hypnosis with some of our providers in our practice. What are your thoughts about that?
Yeah, so and again, when we talk about psychogenic, let's say tick, or the other term is functional. That's kind of the term that we use now nowadays in terms of talking about functional neurologic disorders, functional movement disorders, which include functional tics. And that, obviously is something that is in the differential, especially if it's an older individual in their 20s, 30s that develops tics without a history, and then kind of to this phenomenon I was alluding to earlier over the last year, that a lot of academic centers have been seeing this new onset explosive complex motor and vocal tics in 14 to 17-year-old, particularly females that never had a history of tics. And so the radar goes up, and the ways that I try to look for functional tics in terms of from a history standpoint are, do they have a premonitory urge? Is there temporary expressibility? Is there a relief phenomenon? Are they really stereotyped or not stereotyped? And again, this kind of onset of complex vocal and motor is not something that we typically see. So again, those are ways that I can try to differentiate between true, in a sense, organic tics versus functional tics, because you can see them. And it can be very difficult at times to differentiate. But hopefully that answered your question in terms of the psychogenic functional aspect.
It did. Thank you.
Thanks for asking, Annie. Hey, Angela, are these two surveys the same?
They look the same to me. I'm not
Okay.
Angela, it's Karen, but they look the
Okay,
same to
great.
me.
Okay, I just got onto one of them, so thank you. Thanks for looking.
Thing.
Okay, great.
Yeah, I'm happy to share the survey link as well when we send out the slides and the link to the recording.
Yeah. Based on the survey, this was really great.
Okay.
Like I mean, I'm taking it right now, and yeah, we just want to thank you so much for sharing the evening with us, and just really appreciate everything that you taught us, and being able to have this opportunity is really fantastic. So thank you.
Yeah, thank you both so much.
Yeah, and again, my goal is to try to expand, just to be able to take this back to the community and help the, tick patients that maybe won't have access to other specialists or things like that, and to improve the lives of patients with tics.
Yeah.
We really appreciate it.
I think you did that. So thank you so much.
All right, have a great
Thank you everyone for joining us tonight.
Awesome. Thank you, Dee. I'll send you
Yeah,
the link.
I'll follow up with you tomorrow, Angela. Thank you.
In the slides.
Thank you. Bye.
Bye. Good night, everyone.